Good morning, everyone, and welcome to this first clinical contact session of this year's certificate course of clinical management of HIV. As you all are aware that this course is being offered by the University of Washington, and I thank you all for joining in and getting into this course. And as we had discussed last time in the introductory session, that this will be a certificate course which will run through over 10 weeks, and the format has been like for every week there will be a theme or there will be a topic, and based on that topic 2 lectures will be conducted at the University of Washington, and those lectures will be uploaded on the Canvas. And the expectations from the course is that every participant has to see or listen to those 2 lectures and then meet together to discuss the content of the week, to have a better understanding and to help each other in understanding the concepts. So this year's or this week's topic is diagnosing HIV and the initial evaluation. So already 2 lectures have been done. The first lecture was taken by Dr. Nina Kim, who is again a UW faculty and also the leading the course, and another lecture was done by Dr. Parvez. So as you might have heard in these 2 lectures, and also let's decide on this, that before attending clinical contact session we need to attend these 2 lectures so that we can get the context what we are talking about. As I said, the format expects that all participants should meet together to discuss the week's content and also the share each other's learnings and all that, because we wanted to maximize the learning. But obviously that is not possible in our setting, where we have participants from all over the country here. That is why we selected this webinar as a platform for us for discussion. Unfortunately, there is a limitation to that only one person can speak, but on the other hand, the others can use the chat box for the communication. I know that is not ideal, but that is the best we could arrange for. So when I am speaking here, it doesn't mean that it's like one-sided communication, or I am doing a sort of lecture or something on the topic. What I am trying to do is I am trying to facilitate the discussions which already happened in the lectures, and also I am trying to give the background with the local context or the Indian context. Because if you have gone through these 2 lectures, in the first lecture the faculty discussed about the mainly US based guidelines and also the CDC guidelines on the staging and about the approach to the newly diagnosed HIV positives, but it was more around US and US based guidelines. While in the second lecture the faculty discussed about the guidelines in the low and middle income countries, which basically follow the WHO guidelines, and we are we relate ourselves more to those international guidelines or WHO guidelines. We means I'm talking about NACO guidelines. So in this 1.5 hours or less, or whatever we have time today, we will try to see these topics in relation to the NACO guidelines. And one more thing we need to understand, I think, the difference between these kinds of certificate courses and the usual NACO training or any kind of training you undergo. Because in trainings, if I can give example of NACO trainings, usually the guidelines are disseminated or guidelines are discussed. Usually we don't get much time to go into the background of like why this guidelines or how this guideline is coming or from where these guideline is coming from. So those evidences we don't discuss, but this course actually focuses on that why aspect of the guideline. So every lecture you will see the faculties presenting the the evidences for those particular guidelines. So and that's what we will try to do, that we'll discuss a bit some of the slides from the lectures and some slides from the NACO guidelines, so that we get the holistic picture. And also on the other hand, or most of us are working in the ART centers as ART medical officers, so we don't have a scope to go beyond guidelines and do something in our ART center unless we have approvals from SACS or NACO. So we should keep all that in mind, that while doing the lectures and also while doing the assignments for this course, the course content by the UW faculty, that will be the main source for solving quizzes and all that. But as when it comes to the practice at ART center, it will be 100% followed, or we will 100% follow the national guideline or NACO guidelines for that. And if there are any variations, it has to be approved by the state aid center societies or NACO. Okay, so that was a brief background. In the first lecture, Dr. Nina also gave a small background of the course, just to reiterate what it was already discussed in the course orientation webinars. So that was one more thing which was discussed. So let's start with this contact session, in which, as I said, we'll try to give the background, what was already provided by the UW faculty, and also we'll try to see the local context. So the main objectives of those two lectures were this, that as I said in the first lecture, natural history was discussed, clinical staging, mainly the US based or DHHS guidelines or CDC's clinical staging was discussed, which is unlike us, we follow the WHO clinical staging. Then epidemiology of US was discussed, and also about acute HIV infection, HIV testing, and with the help of some of the case studies, she tried to discuss the what will be the response at that particular time when new patient comes in. While in the second lecture, we saw the epidemiology of global epidemiology and some of these specific interventions which the faculty was doing in some of the African countries, and how those are beneficial. So we will try to see some of the interventions which are not there as a mainstream in the program, but in addition to the present service delivery system, the additional activities which NACO has been doing, that also we'll try to discuss in this session. And also, as I said, this will be the 10 weeks, so whoever is actually willing to facilitate these sessions, please let us know your name, and if you want to follow the next session, we are more than happy that if anyone wants to take or facilitate these clinical contact sessions or Saturday. It is not necessary that every time I need to talk about or I need to facilitate these sessions, but any one of you who is interested can contact Shweta or Praveen or myself, so that we can then make the agenda or the schedule for the 10 weeks accordingly. So please let us know for the remaining 9 sessions. So let's start from the epidemiology, which was not, again, we will not go in very much details of methodology of this data and all that, but some basic facts. UNAIDS in 2017, the new estimates had come up, with which the world has 36.9 million of HIV positives, which comes around 3 crore 69 lakhs of HIV positives estimated population, and 1.8 million new infections in the year 2007, and 2017 AIDS related death were actually 940,000, that is 9,40,000, and this is 18 lakhs. So I think here we also, most of us are actually practitioners, so we don't go much in numbers and epidemiology and those things, because those are basically helpful for the program managers. But it is important to understand few things about these numbers. First of all these are estimated numbers based on certain methodology these estimations are derived. But these days, increasingly, people are talking about epidemic control. So HIV, if it is an epidemic, how it will come under control. So what is epidemic control? Is that when your new infections or the rate of new infection, if they are happening below the your deaths, then sooner or later we will achieve the control of the epidemic. That means the number of people who are dying because of a particular disease, if new infections are lower than that, then you will receive or you will achieve the control of the epidemic soon. So we are far behind that, because you can see that new infections are almost double than the AIDS related deaths which are happening. So a lot of work is still to be done. This is again the same, but region wise it has been shown. Africa has the largest number of PLHIV population, and then after that is Asia and Pacific, that is 5.2 million, where also India is one of them. These are numbers in India. I don't expect everyone to remember all these numbers, but it's good to understand the burden so that we can understand the problem of this epidemic in our region or in our country. So if you look at the general population's prevalence, it is 0.22%, which looks low in terms of percentage, because our population is so huge. So in the total population, what is the number of HIV positive? So that's how it is being projected. That is, it will come to 0.22%. But in terms of numbers, if you see, it is huge. It is 21.4, and the range, if you see, it is almost 16 to 28 lakhs. And men, women, again, if you see the comparison between men infected with HIV and women infected with HIV, it's almost women are 2/5 of the total HIV burden of the country. It's actually more than 2/5. So it's not a small number, which says a lot. We will not go in those details, but still we need to consider that again a huge number of both men and women are infected with HIV. So total new infections, here if you see, these are 87,000, and AIDS related deaths are almost 70,000. These were reported in the year 2017. And so by this also we can see that we are not achieving epidemic control soon, because with new ART treatment and with reduced number of OIs, people will deaths may go down, but again you have to bring down the new infection much below deaths to achieve the epidemic control. Then people who are on ART, this is the data for like March 2018, last year, 1.2 million, that is 12 lakhs plus patients are alive and on ART. So these are again the same figures in terms of what we saw in the last table, but some of the facts are additional here. That if you can see that as far as decline of new infections, annual new infections overall in the country, if we see, it is declining definitely. If you take the base as numbers which are in 1995, the peak of the epidemic, so there is 85% decline from that level. And if you see the 2010 as a baseline, there, we have achieved 75% of decline. But again, we are not achieving epidemic control, because again, almost close to 70,000 patients are dying because of HIV. And as we saw before, our number of new infections are again more than that. So now wherever you are working in whatever ART center, you need to know about, first of all, the national scenario. And I'll tell you why these things are important. As a clinician, you may or may not have given importance to these things before, but I think the leadership should be from the ART center who is managing actually all this burden, because once the person, ICTC or testing facilities, usually patients will go there once or twice. But once the person is diagnosed as positive, will remain with the ART center lifelong. So we need to understand why our load is increasing these days, and which is very, answer to that is very simple because of like this ART, TTOL and all that. But will it happen the same way, or what will happen like 5 years down the line, or in future? And are we on the right track or not? When I talk about like are we, so we should talk about like what is the national scenario, what is my state doing, or how my state is doing, and how my district is doing, and then how my ART center is doing. So in terms of total estimates, if you divide state-wise, Maharashtra is on the top. Earlier Andhra was on the top, but Andhra, Telangana divide again distributed the PLHIV population as well. So Andhra now is on number 2, Karnataka number 3, and Telangana number 4. So these are state-wise distribution of the estimates, and this is other remaining states, which contributes to 19% of the total national burden. And in terms of new infections, if you see, Maharashtra, though it is a number 1 in terms of like total burden, but in terms of new infections are going down in Maharashtra. But some of the states like Telangana, for example, 11% new infections are coming from Telangana, Bihar, West Bengal, UP, Andhra Pradesh. Now, see, these states, earlier we used to say that, okay, HIV is more in the southern part of the country, and also the northeastern part of the country, but other states we don't have that bigger issue. But here you can see that these states where we said that problem is not that much, but slowly you can see the rising trends in this. I'm not saying that new infections are increasing, but overall estimates, if you see, earlier we didn't see this much, but now they are in terms of new infection. Now Bihar is on number 2. Now these are like, it's a huge problem out not only in this but in the other states also. Even though it is reducing, but still we have annual new infections which are to be curtailed. We have been saying since beginning that this disease is a concentrated epidemic, which means there are some groups where HIV positive burden is high, and you can see here that program has identified some groups for the intervention. We call them as targeted intervention programs. So the targets are mainly there are the listed here are those main groups. So broad categories are core group, bridge population, and general population. So those where at high risk or where the infection is said to be concentrated more is IDU, Hijras or transsexual, transgender, MSM, and female sex workers. So here it is said that the disease is more concentrated, and here you can see the percentage of positivity in these groups, highest being in IDU because of the very reason that the way they take injections. And the global term for IDU these days, because you will see in the other presentations of the UW faculty, it will be said as a PWID or PIVIDs, people who inject drugs. But in the national program, we use the term IDU, and we continue to use the same term. So I think you should be aware of both these two terms, IDU and PWID, which means people who inject drugs. Northeastern states have major issues with this population because the more positivity we have seen in the northeastern states, and while in the other parts of the country we didn't see much problem of the IDUs, though it is there in the major cities of the other states as well. These two groups are called as bridge population, single male migrant, or actually it is single migrant, you can say. Now this term is changed. It's called as high risk migrants, and long distance truckers. These are bridge population, and this is the general population. Now why this is important to understand is because all your cities, wherever you are practicing, will be having TI-NGOs. And ART center in our program, unfortunately, there has been a very I should say a disconnect between the way ART center functions and prevention machineries they function. So I think this is the time where there should be handshake between all the stakeholders. So the simplest way can be you can have coordination meetings with the TI NGOs just to ensure that whoever is positive in the registered in targeted intervention NGOs should be on ART from your ART center. So if you don't know this, ask this question to the TI or your DAPCO or wherever the district functionary is. So get to know that all the key population groups or key population clients, all these are called as key population groups or clients, they should be on ART. Now there is another issue here that sometimes in last few years you might have seen that positivities in these TIs is going down, but in your ART centers key population clients are getting registered. So there is another issue here, that even though we are saying that our national program or the epidemic is concentrated, but we continue to see that positivity in TIs is going down, but there will be KPs who are not registered in those TIs, but they belong to the key population, and then positivity is also there in those key population groups. What I'm trying to say here is the key population clients which are reported by the ART center usually doesn't match with the key population who are positive, which is being reported by the TI NGOs. So I think both of these facilities need to talk to each other and have frequent meetings to get the real picture, and this is just to ensure that every key population client who is HIV positive should be on ART, because if you leave even one person who belong to key population group who is positive suppose and not on ART, imagine the spread of infection, what will happen because of the high risk behaviors. So if you want to reduce the new infection, we have to have all the key population clients who are positive on ART. Why I'm telling all this to you is because till now ART center have not thought much about of course, we in the ART center we talk about all patients when whoever comes to us, but on one step behind, we should also see that is it reaching everyone who is HIV positive, and the priority group should be the key population, where we know that if we don't treat them, they will continue spreading HIV knowingly, unknowingly. So these are current goals and targets of the national program by 2020, which is not far. It is actually next year. We just have 1 year to achieve all these things. Achieve treatment targets of 1990. Now we'll come back to this 1990. By next year, if this is our target, how close or how far we are from this target, that we should know. And again, when you plot this 1990 graph or whatever the chart, nationally where the program is, that will be seen by NACO. But I think in our city, our state, our district, our ART center, we should see by ourselves where we stand. And for that, the most crucial thing for ART center is to just pick up your monthly progress report and see the indicator 2.11. There is a cascade for the new patients. That number of patients you are registering in your centers, how many of them went on to the ART, and what is the retention of these clients. What does retention means? Once you start ART to these clients, how many are still alive and on ART at the end of 12 months? That decides. And if you will be surprised to know that NACO's retention numbers is 75%, which means we are losing. If suppose you are starting 100 patients on ART, you are losing 25 patients out of them, and you have only 75 patients on ART. So these 25 may be deaths or loss to follow-ups or missed or whatever which is happening to them. So this is just 12 months retention, which is not good. So if you want to achieve 1990 by 2020, imagine how far we are. And every center, I think, should take a stock of their own numbers. And if there are any gaps, I think we should be working on these gaps. And this is the reason I'm actually going on this details of numbers and all that, because my perspective, my general perception is like, we as ART medical officer, we usually don't think much in terms of numbers and all that, but those are important. It has its own importance, but at least few basic things we should be aware of. So reduce new infections by 75% is the again goal and target. Eliminate HIV related stigma and discrimination. Eliminate mother to child transmission. These are units, fast targets, and if you can achieve all this, we can end the epidemic of AIDS by 2030. That is the Sustainable Development Goals. And this is the 5-pronged strategy which is being used by NACO for prevention, care support and treatment, strategic information and management systems, institutional strengthening, and IC for all these whatever we do. So usually ART center works around care support and treatment related activities, but again, as we mentioned, prevention is something which comes from again ART as well. So if you put all the patients or clients on ART who are HIV positives, you are contributing a lot to for prevention. And this is the 3-tier system which is followed in our program. So at the base, in the middle, you have ART centers, or usually ART centers are located at the district or sub-district levels. And in some of the regions, within 4 to 5 districts, you have just one ART center. That is also a possibility. And below the district level, you have Link ART or Link ART Plus centers. Or this is a kind of differentiated service delivery model which came up long back in our system, but then we didn't call that as a differentiated service delivery. This term we'll be using in future slides as well. So we'll talk about what it is and how does it work. But this is again to give ART to those who cannot travel long distances to receive ART. So in the program, we have centers of excellence, like 17 centers of excellence, and also ART plus centers who are equipped to give ART or change the ART from first line to second line. So we have 99 centers like that. So every state has at least one ART plus center, and many states have more than one. For example, Maharashtra has close to 10 ART plus centers. So we have 17 centers of excellence, 11 COEs, and 7 pediatric centers of excellence, 80 ART plus center who has SASEPs or state AIDS clinical expert panels. Care and support centers, the numbers have reduced, if you have observed. So now it is 310 care and support centers. So again, these services are again decided, or number of ART centers, number of facilities are decided based on the load of PLHIV your region or your state or district has. Care and support centers are earlier, if you remember, we had community care centers or drop-in centers and or district level networks. So all these are merged together to form care and support centers. So in the division of care support and treatment, ART center mainly focuses on the treatment and activities around the treatment, while care and support centers focus on first two aspects. So they have multiple responsibilities. There is separate guidelines, CSC guidelines. If you can see, you can just go on NACO website and download and see. So it has many functions which you may already know. This was the scale up which has happened in the last few years. I'll not go in details, but just to let you know and reiterate again that we have 1.2 million, that is 12 lakhs plus patients who are alive on ERT, and this is coming from your MPR and IMS. So in the MPR, the indicator 3.10 is actually alive on ART, and when you submit your monthly report, out of 540 ART centers, so all this alive on ART becomes the number of patients who are on ART at the nationally. So that's your number. Okay, so after this epidemiology or numbers and this importance of that, whatever we discussed, just right away we are getting into the basics of HIV. You all know all these things. So I'll just skip through slides. Basically, our epidemic is also the most of the infections are happening because of the heterosexual route. More than 90% or 95% infections because of the heterosexual route, if we are seeing the reported figures. But as an ART center, I think one comment I would like to make is when your counselor does the risk assessment of the client, which is recorded on the white card in the section 2. So the risk of so in the first meeting with the counselor, the client may or may not mention what was the mode of transmission, or what was the risk that person has underwent. Every time it will be ticked on heterosexual. So the point I want to make here is the client may disclose the risk later in the service. So whenever that happens, that risk should be updated on the white card so that the program gets the accurate data from the ART clinics as well. So for example, if the client is a key population client, that also has to be recorded. So in all, there are the blood and blood products is one route of transmission, needle sharing and needle stick injury. Again, there is a difference between these two, needle stick injury and needle sharing. Some of us believe that if we get the prick, it is same as needle sharing, which is, these two things are very, very different from each other. The risk of transmission because of needle stick injuries is very low, it is 0.3%. But needle sharing, it is very high because the way the drug injectors, they take the drugs. So they pull in the blood and the next person pushes the infected syringe with again drug, so that the direct transmission of HIV, there are high risks. Then again, mother to child transmission or parent to child transmission, which happens. And this, I think we should be knowing that level of risk through these exposure routes, because when you do counseling of a new client, when the new client comes to you and when you do counseling, I think these percentages usually help you in doing counseling, especially when in the scenario of post-exposure prophylaxis. So for example, if nurse comes to you with needle stick injury, you should know that what is the risk of transmission because of the needle stick injuries. Someone suppose comes to you and say, okay, I had sex without condoms, or condom got ruptured, so you should know what is the risk because of the risk of transmission of the sexual route, again vaginal, anal, oral. So these are the things which help us in actually counseling of those clients who are exposed to risk of HIV. So this is again good to remember, and because it helps in counseling. So this is what we were talking about, that 94% in the program data we have reported that it is because of heterosexual route, which may be again true, but it may be lesser as well because it's again program data. But yeah, so we have to believe it. So how it happens, if you take example of sexual route, the HIV enters the sexual fluids, that is vaginal secretions and semen or seminal fluid has HIV virus. In fact, the viral load in these secretions may be much higher than the blood as well. So if the genital mucosa is breached because of anything like infections or any abrasion or whatever, so when sex happens, if one partner has HIV virus, then as the virus is exposed to the genital mucosa, if gets in from the genital mucosa, then it is carried to the regional lymph node through the dendritic cells, and then in the regional lymph node there is exponential multiplication, and there will be widespread dissemination of the virus within 5 to 11 days. Now again, in the regional in this, if you see the virus, if the PP is introduced immediately, then the risk of transmission or risk of becoming positive reduces a lot, especially if it is taken within 2 hours time. There is a separate session on PEP, so we'll talk about details there. But here, I think we should just remember that how it gets in and how it causes HIV. So here is a virus, this is the mucosa, and these are the dendritic cells and our antigen presenting cells. They'll take this HIV virus to the regional lymph node, and there will be exponential multiplication and spread. There are some of the organs to whom HIV directly acts, and also HIV remains there as reservoir sites for them. So if this is the virus has an RNA inside, single-stranded RNA, and it has three enzymes: reverse transcriptase, integrase, and protease. So the first step is single-stranded RNA gets converted into double-stranded DNA by reverse transcriptase enzyme, and most of the drugs which we use in the national programs are reverse transcriptase inhibitors, like tenofovir, zidovudin, lamivudin, abacavir, even efavirenz, nevirapine. All these are reverse transcriptase inhibitors. There are some nucleoside, some nucleotide, some non-nucleoside reverse transcriptase inhibitors. But their role is here. They prevent or they block this conversion from single-stranded RNA to double-stranded DNA. So this double-stranded proviral DNA is carried to the, this is human DNA, and the second enzyme of the HIV virus, that is integrase, takes this this viral DNA to the nucleus and gets integrated into the human DNA. So it is now the human DNA has the part of the viral DNA as well. So this stage or this integration can be blocked by a group of drug which is called as integrase inhibitors. So we will see this again in the session of the ART, but this is just a quick summary of that. And then messenger RNA comes out, and there smaller proteins or longer proteins are formed. Those proteins are cut into smaller size proteins by the third enzyme, that is protease, and the virus takes the envelope and goes out in the new virion. So basically, one virus, first stage is actually attachment, where you have a receptor which is called a CD4 receptor. This cell is actually a T lymphocyte, and those T lymphocytes on the surface of which there is a CD4 receptor are called as CD4 type of T lymphocyte or CD4 cell, which is actually a receptor for HIV virus. So that is how HIV selects its target for multiplication, and new viral copies are formed. During this process, this cell gets damaged, and slowly CD4 depletion happens, and number of HIV viruses, it goes up. So there are different stages of HIV infection. First there is a transmission, then acute retroviral syndrome, we will come back to this, then seroconversion, that means the antibody test which we do, which was earlier negative and now it is coming positive, then asymptomatic chronic HIV infection and symptomatic HIV infection or AIDS. So this graph you have seen in the lecture which was taken by the first faculty, and here you can see that in the first few weeks, now below this breaking line, this is in weeks and then it is in years, this x-axis. So when HIV enters, there will be the viral load will go high like anything, and then the immunity comes into action, and then viral load goes down and settles to a level which is called as viral set point or virological set point. Also, immunity dips in the beginning, but immunity again regains its status, and there will be an immunological set point as well. But slowly down the line, what happens is your viral load increases and CD4 goes down, and there in the last stages it is called as stage of AIDS, because immunity is very low, viral load is very high, and there is a risk of opportunistic infection, and that's how patients may get more and more opportunistic infection, and this is called as stage of AIDS. So this again slide was discussed a lot by the UW faculty, because this helps in understanding the risk of HIV transmission by stage of infection. That means obviously, see, everything comes down to the viral load. If viral load is high, risk of transmission will be high. If viral load is low, risk of transmission is low. They even go to an extent and say that if viral load is undetectable, then HIV becomes untransmissible. You might have heard this phrase, undetectable is equal to untransmissible, or U is equal to U. Obviously, this is for the sexual transmissions of HIV. So, if as we saw in the previous slide, that initially in acute stage of retroviral syndrome, the viral load will be very high, and that is where the risk of transmission will be huge. That is one risk of transmission per coital act, 1 per 50 to 1 per 250 transmission per coital act can happen. While if the viral load is stable or undetectable, then you can see that from 1000 coital act, one transmission may happen, or 1000 to 10,000. That is where you might remember that is 0.1 to 10% is coming from. So, and it depends, everything is dependent on the viral load, which we say that usually this phase we don't get patients in this stage, because when acute retroviral syndrome happens, it is like any other viral infection. Patients may feel some symptoms, but usually we don't detect HIV there. But the risk is that in this stage of his or her disease, the person spreads or is at risk of spreading HIV a lot. That is why it is important to diagnose HIV as early as possible, so that we can put the person on ART, so that the risk of transmission reduces. And another extreme is in the late phases of infection, where the viral load again goes high. But in between, it may be low risk of transmission. But once you put the person on ART, again the goal is to bring down the viral load to undetectable levels, so that the person is person will not be in a position to spread HIV virus. Everyone knows about it. Whenever CD4 declines, the risk of OI increases. So if it goes below 350, again more and more OIs will come, especially if it goes below 200. Large number of OIs may appear as infections and diseases, and the way in which they manifest themselves, for example, TB, if it can happen at any CD4 time, but TB happening at 450 CD4 level and 50 CD4 level is a bit different. Here it is like any other immunocompetent person, where you will see cavities and all that, but if the CD4 is less than 200, then there will be disseminated TB with lot of lymph nodes, pleural effusions, and TB meningitis, and all of that sort. And there are some OIs which happen when CD4 goes below 200. That is, for example, PCP, and then cryptomeningitis or toxoplasmosis, or some OIs like PML, that is multifocal leukoencephalopathy, and cytomegalovirus infection, and MAC, that is Mycobacterium avium intracellular complex infection. So these infections, they happen when CD4 is very low. For some of the infection, we give prophylaxis, for example, cotrimoxazole prophylaxis and INH. Now, all our patients, we can divide them into various categories, but this is just a theory to know that how the decline of CD4 is expected. We never know that which patient will become a typical progressor, or rapid progressor, or slow progressor, or long-term non-progressor. This slide is just to make a point that all your patients may behave differently. So don't apply one patient's for example, patients may compare themselves within themselves. So one person says, okay, I'm not on ART since like last 10 years, but still my CD4 is 500. Same thing doesn't apply to the other patients. So other patients, CD4 may deteriorate in 2 months, and this patient's CD4 since last 10 years might not have deteriorated. Or even without ART, you might see some slight increase in CD4 sometimes. But these are the things which you cannot predict. And why this slide? Because this will give you something to talk to those clients who think like this. So when our people, when I say you, it is not only the ART medical officer, it is about the counselors and our ART center actually. So to help our patients, our people should know that two patients may not be same. The way in which a person's HIV behaves for one person may be completely different in another person. So this is important, that we should know that most of the patients are typical progressors, but Some are rapid progressors, almost 10%, where you will see like 50 cells CD4 drop in a month's time, where typical progressors were taking 1 year to have CD4 drop of 50. Slow progressors 5 to 15%, long-term non-progressors they are taking like 5 to 10%, but nothing is happening to them for like even more than 15 years. Now this is again from the UW faculty slide. When she presented a case, she was discussing about what is to be done when a new patient comes in. So this also when we practice at ART center, when new patients come into our ART clinics, we I think should first be open to ask the client, because sometimes what happens is patient is received by the counselor and counselor will say, okay, you need to get these investigations done, and then patient directly goes to the lab and for investigation and comes back. This is actually a bad practice, because sometimes patient will come with lot of expectations but if they don't get those things, they become lost to follow-up and you will lose those patients very soon. So first few months in the ART center, those are crucial for long-term retention. Did you get it? Like most of the LFUs are happening between first 3 to 6 months. There are a lot of reasons for that, but preparation to avoid this miss and loss to follow-up. Once you take care of your client for first 6 months to 1 year, then the chances of becoming LFU are less than like 5%. LFU means I'm including death and other that also. But if that person becomes LFU, and in the chances of becoming LFU in the first like 3 to 6 or first 1 year, you will see it is like more than 25%. So it depends a lot in which the ART center caters to the new patients. So first of all, as an ART center, we need to make sure that whoever is being sent to the ART center in whatever duration of the working hours, maybe in the morning or afternoon or evening or whatever, whenever the ART center is open, so that person should be taken care of very well, or should be received very well, should be given enough time. I know that people may talk about like we have huge patient load, then how can we give this amount of time, but believe me, new patients, they deserve that amount of time. And that is how we need to differentiate the services, in our ART center. So invest more time in the new patients. Start from asking them that like when do you know first about your HIV positive status? What was the life before that? What is the life after that? And then what happened, or the chronology, or the sequence of incidences, that when you got diagnosed as HIV, what happened after that? When did you get admitted anywhere? Did you get treatment for TB? And then what happened? Did you go to the private practitioner? Did the private practitioner give you the drugs which were expensive? If they don't have any evidence of ART, you can ask the indirect questions to know whether the client was exposed to ART before or not. Because by the time, usually the behavior in our setups is not like that. If I get HIV, I'll not go directly to the ART center first. So I'll go to my family physician first, or some private practitioner, and will spend some like almost months together there, listening to their advices and treatments and all that. But when financially I am compromised, then I turn towards ART center. So when new patient comes into the ART clinics, lot might have happened earlier to that. So our people should be equipped enough, especially counselor, to get these details of ART and previous history and all that. ART counselors and also medical officers, because counselors focus on usually the first like social backgrounds and risk assessment and all that. But as a medical officer, I think we should have a good history and invest more time in the beginning itself, so that, for example, other comorbid conditions like diabetes, hypertension and all that. So all these things matter. And your white card is actually a proof of that you have so many sections in the white card, just to ensure that our medical officers, they take all this history and record that on the white card, which will help you in future to deal with your client. But If you don't believe me, go back to your ART center and just look at your white cards, how sections 4 to 12 are filled, or 4 to 11 are filled. So most of the sections you will see blank. I understand that you may not get time for all patients, but that's what I'm trying to say, that how many new patients you are getting in a day or in a month. So give more time to those patients who require more time. So you need to play smart there, that don't just like a person who is taking ART since 10 years may not require like more than 2 minutes for me to see or in the ART center, but the person who has newly come in, the person who is failing the treatment, the person who has more than 1000 of viral load, the person who has complaints, or those who are not clinically stable, these are the patients who take more time, and in your whole OPD only 10 to 20% patients will be of this kind. Remaining 80% of the patients, you can quickly see them and they will be happy to go off. And those are like chronic patients, and you don't find loss to follow up in most of them. But these are the patients you need to identify and talk to them, and then go stepwise so that you don't miss anything in your new patients. Obviously, it is not a death sentence these days. It is like any other chronic manageable disease. But it is easier to say, but it is difficult when it comes to actual counseling. You can never assume that what is going in patients' minds. So don't hesitate in asking questions, but questions should be well directed. For example, knowing the risk, or the curiosity of how the person might have got HIV. For example, if a young like 20 years boy comes to me who is HIV positive, then, or girl comes to me who is HIV positive, and immediately at that point of time, counselor might have taken the risk profiling. But as a practitioner, it doesn't make any difference for me if a person has got HIV through sexual route, or blood transfusion, or whatever route of transmission it is. So the questions should not be asked to satisfy our curiosity, but if we are going to do something which is to reduce the further risk, or to strengthen the positive prevention in that particular client, then it is okay. But and some of the new people who join into this HIV practice, they actually fail to differentiate between these two things. So that is one basic thing. I think we need to listen to the patients, and then to help the patient out, whatever you require, you can ask those questions, but frame those questions properly so that you gain the confidence of the client, and then it is easier to follow that client up in the later phase of the treatment. Dr. Nina talked about the acute retroviral syndrome and history of that. Basically, in this acute retroviral syndrome, the symptoms or clinical features are not very different from many other viral illnesses. So that is why we tend to usually miss it. But if you see, if someone has weight loss, and this is what she had actually focused in her session as well, the crude odds ratio for weight loss and genital ulcer is quite significant. So even though the symptoms are very overlapping with any other disease also, but anyone who is complaining of the weight loss or having genital ulcers, which I again, this is one area where ART center medical officer, I have seen very few of them reporting any STIs. I'm not saying that it's or you can very well say that okay, we have huge patient loads and all that, but as I said, invest your quality time for new patients, or at least if someone complains, have a look at the lesion and report the lesion properly, so that you will know that what is happening to these patients. And if some new patients are coming in with weight loss or genital ulcers and all that, then I think it is HIV has to be ruled out in those clients. So in acute retroviral syndrome, this is again lesions, skin lesions you can see, and also the oral ulcers in acute HIV infection. So she discussed in details about acute HIV infections, but The bottom line is again, what is the importance of knowing the earlier HIV positivity, that is early diagnosis of HIV. The main basic thing is, as soon as we diagnose the client, or first diagnose early, as soon as we diagnose, put them on ART as soon as possible, so that you extend the life of that person and also you reduce the risk of transmission of HIV to others. So she also discussed about the basic HIV testing guidelines, or tests which are available. There are many tests which are available. You might have heard about this P24 antigen testing, or antigen based or antibody based testing, or nucleic acid based testing. So there are various methods which are used, but in the national program, again, for diagnosis, most sensitive tests are being used, and sequential testing is being used. That is, on the same sample we use a test twice. So the sensitivity of the rapid test which we perform in the national program, it is 99.7% and more sensitivity, and we do that in sequence. That is, next test immediately we do if the first test is positive, just to confirm. And we need not do Western blot test these days. Actually, we do 3 tests, and Western blot is actually done if the tiebreaker fails in the third test. And in the blood banks, we use 4th generation ELISA. I'm not sure if we are doing 4th generation ELISA at ICTCs also. 4th generation ELISA means it can test antigen antibody both. Then viral load, obviously we do viral load testing, not for diagnosis but for monitoring. So this we already discussed, that HIV virus has a RNA and also 3 enzymes: reverse transcriptase, protease, and integrase. And also this is viral envelope, which is GP120, GP41. This is again seen when you do Western blot test. You can see these are envelope proteins of the HIV virus. So these are various types of tests: serology, antigen test, DNA PCR, and viral isolation and culture, which is obviously not used in the clinical practice. It is used for research purposes. And every lab test will have a window period. That means if today a person receives HIV virus, you cannot diagnose HIV today. So there is a window period. So typical window period for antibody based tests, that is rapid test which we use, is 2 to 12 weeks. But for antigen based tests also, it may take like 10 days to for the test to come positive. So 2 weeks is ideal time for doing any kind of test, because again, negative test, if you do it today also, if a person have high risk behavior, it may just rule out the previous already acquired HIV infection, but cannot guarantee that it has ruled out the infection if the person might have get because of the today's high risk activity. So the negative test will not rule out the HIV status of that client. So antibodies, usually it will not be there. Once they appear, usually they stays in the person's body. What is the maximum? There is a question actually. What is the maximum seroconversion time in any case? The typical window period for seroconversion, which means that antibody negative to antibody positive, is 2 to 12 weeks. That is 15 days to 3 months. That is why in the ICTC program or in the NACO program, if you see when they do the test, they say that it should be repeated after 3 months and 6 months if the tests are negative. That is what they do. Can it go more than 3 months? I'm not sure if it can go beyond 3 months because of that particular infection, because that is what window period is usually said. But if you can ensure that no this thing or reinfection or re-exposure has happened in that period of time, which is sometimes it is difficult to ensure. About the PEP, I think we can talk about PEP later. It has a separate session. Using NAT for diagnosis while patient is on PEP is recommended. We'll talk about guidelines and other things about PEP later. I think, yeah. HIV2 window period. Is there any separate window period for HIV2? I'm not aware of if it is separate window period as such for HIV2. But if window period, if antibody has to appear, it should not be different for HIV to for antibody to appear. The difference between HIV 1 and 2, that is again, obviously it is those are two different viruses, even though they are HIV, but they behave differently. The as far as long term the effect of the spread of HIV. HIV spread, one spreads fast, two spreads slow, and the response to treatment is different. But as far as development of antibodies to these viruses is concerned, I don't think there is a difference between these two. Can HIV RNA assay be detected as early as 7 days? I would say it is very less likely, because if you remember the picture we saw, for dissemination to happen, some cases it might happen. It take like 5 to 11 days dissemination can happen, unless the virus is disseminated in the blood. If you remember that graph earlier, which we picture that we saw, that dissemination takes 5 to 11 days. So RNA assays, again the same thing applies here, that if you do early and if it is negative, you cannot rule out HIV at that point of time. That is why it is wise to actually defer these tests for at least 2 weeks. That is what is recommended. Okay. So these are again pictures of some of the tests which are being used in the program. That is TriDot we use, Triline we used. Don't we have qualitative test for HIV infection? We use DNA PCR, which is RNA PCR is a quantitative test, but DNA PCR is qualitative. Lab stating that NAT can detect as early as 11 days. Is it? Yes, that's what we said, that it depends on what test you are doing. It can detect early, and yeah, you're right, it can detect as early as 11 days or 15 days also. More than 10 days also it can detect. But what I'm trying to say is, if it is negative at that point of time, it can not rule out the virus itself. We'll have to retest again. Which test is more sensitive, P24 antigen or HIV RNA? Oh, see, P24 antigen is something which appears and disappears. I'll show you another slide. By the way, this is ELISA. The way it is done, it is a bit complicated to perform, and rapid tests are easy to perform. See, usually this P24 antigen, it appears and disappears, and then later it may be negative also. Sometimes people use this evidence to declare the client as HIV negative. So it is not good to make or establish a diagnosis. Okay, early days you can do P24 antigen testing, but not to establish the diagnosis, because like I said, it disappears later. But HIV RNA, once it appears and if it is there, the quantification, the number of RNAs you can see. But again, the number is used for monitoring. But if numbers go below detectable levels, you cannot monitor. This is usually HIV RNA testing is used for monitoring of the patient as a response to therapy. It is not used as a diagnostic test. For diagnosis, we use DNA PCR, where we see whether the person is DNA PCR positive or negative. Okay, I think those were my comments on that. Window period we already saw, and these are like increasingly we are moving towards using 4th generation ELISA, which can detect antigen and antibody both, for better diagnosis of HIV clients. And this is the reason why it came into first in the blood banks, because blood banks, we were earlier doing only antibody based testing, but again, if someone is in window period and donates blood, it was difficult to identify positivity in those clients, and they became source of infection. So that is why 4th generation ELISA was first used in the blood bank in our program, so that it tests antigen and antibody both. So I'll skip some of these slides because you know that how testing is being performed. Okay, so let's talk about these WHO clinical staging and CDC staging. There might be some questions on this also in your quizzes. So CDC classification of HIV staging, it has 3 stages, very simple. More than or equal to 500 if it is stage 1, 200 to 499 stage 2, stage 3 if the CD4 is less than 200. But if the client has whatever CD4, but if the client has age defining condition, then it will be stage 3. If this client has suppose CD4 500, but if it is the client has age defining condition, that will be stage 3. So what is age defining condition? There is a long list again. So you can go through this long list, and any of this condition with any CD4, it will be stage 3 as far as CDC staging is concerned. In our program, we don't do CDC staging. In our program, we do WHO clinical staging. So this is what WHO clinical staging is. Clinical staging 1 is either asymptomatic or persistent generalized lymphadenopathy. That means lymph nodes of more than 1 centimeter size, involving more than two or more non-contagious sites and persisting for more than 3 months. Usually we don't see here. Asymptomatic is stage 1. In stage 2, there will be minor skin infections and some body weight loss, but it is less than 10% weight loss of body weight, and minor skin infections and upper respiratory tract infection, that is sinusitis, otitis media, pharyngitis and others. Skin infection, herpes zoster, angular cheilitis, oral ulcerations, papular pruritic eruptions, fungal infections, seborrheic dermatitis, all these are minor skin infections. Bit different in children, so the difference has been highlighted in red. Unexplained persistent hepatosplenomegaly, for example, it is stage 2 in children. Lineal gingival erythema, where you can see a red marking over the gingiva of the child. So that is another condition in stage 2 for children. Then extensive wart and molluscum contagiosum and unexplained persistent parotid enlargement, all these are stage 2 conditions for children. This is important to stage a client in our center when they come in, because you will then know the clinical status of the client. Because all the staging, if the conditions in the staging, if you see, some are some conditions you can report them, or based on which you can do the reporting. These are like based on your clinical examination findings. But for some conditions, you require lab test results. For example, if a person is having headache, you cannot report that as a stage 4 for clinical for cryptococcal meningitis. You have to do lumbar puncture, you have to do the CSF examination, and if you get the cryptococcal antigen positivity or cryptococcus positivity, then you say that this is stage 4 condition, right? So it is not always about based on symptoms we do the staging. Some conditions you do staging based on symptoms. For example, weight loss is a symptom or a sign or symptom, and based on which you do the report in the clinical staging. But based on headache, you cannot do. So you need to have a report for cryptomeningitis, and then you put the patient in stage 4. So stage 3, more than 10% body weight, person has chronic diarrhea or unexplained fever, oral candidiasis, oral hairy leukoplakia, pulmonary TB, and severe bacterial infections. So unexplained chronic diarrhea more than 14 days in children is okay to report that client as a stage 3. And lymph node tuberculosis, usually in adults it is stage 4, that is extrapulmonary, but in children it is stage 3. We'll go in details of the OIs when OI sessions come. So some additional conditions in necrotizing ulcerative stomatitis and unexplained anemia are stage 3 conditions. In children there are LIP, that is lymphoid interstitial pneumonitis, is stage 3. And HIV associated lung diseases including bronchiectasis is also stage 3. So if you can remember the chronology from asymptomatic, we are going towards disseminated complicated infections. So in stage 4, all are like disseminated and fungal, viral and complicated infections. All are, it's a long list like of 3 slides. I'm not going in details of that. You can just refer to this document, keep under your desk, and whenever patient comes in, if they have any complaints or if you diagnose any OI, you can see where the OI fits in. Based on that, you can decide the stage of the client. If HIV with diabetes mellitus, which stage? Diabetes mellitus, I hope that is diabetes mellitus you're talking about. DM is it diabetes mellitus? So these are comorbidities. Yeah. So this is, again, see, we need to understand why this staging is coming up. So based on the immunological status of the client, we want to know that how the person's immunity status is, or in which stage of HIV infection the person is. Now diabetes has nothing to do directly with HIV. Of course, it has something to do with the ART and all that, but with HIV, it has nothing to do with. So it is a comorbid condition. For example, hepatitis B and C. You won't see hepatitis B and C in this list of WHO clinical staging. It is a comorbidity or co-infection, right? So similarly, diabetes, hypertension, these are comorbid conditions, which is not a part of staging. Okay. So these are all, majority of them are opportunistic infections, and those malignancies which are actually because of the low immune status, people get viral infections and then develop in malignancies as well. So all this is happening because of the lower immunity of the PLHIV. Okay, after the current OI is resolved, does the stage change? See, usually you need to know a bit about why the staging came up. When we didn't have CD4 and other monitoring facilities, we used to use staging to decide whether to do viral CD4 test or not, whether to start ART or not. So you remember the earlier guidelines, only stage 3 and 4 were eligible for ART, so irrespective of CD4 count. Now the things have changed. Now we do start ART for everyone, but we monitor the clients who are coming to us in every visit. So every visit we need to do clinical staging. So even when we say that staging at the time of ART initiation was like stage 3, for example, the person will remain in stage 3 at the time of initiation. But now if the person does not have any symptom, does not have any OI, then I will report that person as a stage 1 patient, right? So in this way it changes. Why there is discordance in viral load and CD4 count? We get a lot of reportable VR in viral load not detected and CD4 very low. Yeah, this is called as virological immunological discordance. It is a known phenomenon. Whenever this thing happens, that you have viral load undetectable and also CD4 very low, we ask people to rule out HIV2 number one. Then also co-infections with hepatitis C can also bring it down, can cause this discordance. One of the reasons can also be like to rule because of other other diseases which result in immunosuppression. So and also if the patients are on steroids or any other drugs which actually cause immunity to get suppressed. In those scenarios, you will see the low viral load and also low CD4 count. So it is called as virological immunological discordance. So in the year 2017, in the month of May, these guidelines were launched, and since then the way we have increased our ART patients in our ART centers is commendable. If you can see your ART initiation in that particular year, it was huge. So treat all is now the guideline, that irrespective of CD4 WHO clinical stage, age or sex or population group, we start ART in everyone. One more thing about the WHO clinical staging is, once you start ART and then when you record the clinical stage of the client, we record in terms of T staging. That means if the person is not on ART, we will say WHO clinical stage 1 or 2 or 3 or 4. But if the person is on ART, we will say WHO clinical stage T1, T2, T3 or T4. So before ART initiation, in our ART centers, like we were talking about before, like person goes to the counselor for risk assessment, gets registration done, then gets baseline investigation done, and pre-existing OI, if there are any, that are to be ruled out. And if you need to start prophylaxis, that we start cotrimoxazole prophylaxis. Or then preparedness counseling is one of the most important phase, and then timely initiation of ART. But all these steps, though they are important, they should not be barrier for ART initiation. That we should remember. all these things are ideal and all these things are important. But if they become barrier, for example, if someone does not have, suppose, the whole liver function test profile, so I cannot keep the patient waiting for that one profile, and if it doesn't come for like 2 months, I cannot make the patient wait because this was not available. For example, USG abdomen. Some of the centers I have seen USG abdomen, now it is not a mandatory baseline investigation also. So some of the centers, unless USG abdomen is done, will not start ART. So that is wrong actually. So patients are more at risk of death because they are not on ART than if you start ART, what will happen to them. So bottom line is to start ART as soon as possible. I'm not saying that even if the person has some problem, you go and start ART on the same day. I'm not advocating that. But you are the best people to decide which patient needs how much time for preparation and initiation of ART. We have to make it a point that the people should receive ART as soon as possible or as early as possible. Even in our guideline, if you can see, even below in a week's time you can start ART to those clients. But if you know that the client is not going to come back and client doesn't have any signs and symptoms, there are minimum tests which are available. So you may start ART quickly in those clients. So there are some questions. What are basic blood tests because there is a big list and essential criteria before inducting a patient on ART. Yeah, so there is a list which let's come to that directly. So before doing blood investigations, as we discussed, we have to take this history of patient, especially drug history, which we record in section 4 of the white card. This has to be taken in great details. And then about the social history and all that, this has to be recorded on the white card again by the medical officer. And we do vitals examination, oral cavity examination. This is the most important thing, oral and genitalia. So both the things are important. The reason why you are looking at the oral cavity, for the same reason you also should look at the genitalia. So you will find some ulcers or whatever STIs and all that. And then lymph node, skin, eyes and fundus examination, especially if the CD4 is much more less, that is less than 100 or less than 50. Then systemic examination based on which system you think of like contributing more. Genital examination and evaluation of hypertension and diabetes. Again, the system of examination, it is the way it is being written. This is actually a quick examination of head to toe that we should be knowing while we work at the busy ART clinics. So these are the essential tests which NACO says that they have to be done: hemogram, urine routine micro, fasting blood sugar, serum creat, blood urea, serum albumin, SGPT, VDRL, CD4, X-ray, lipid profile, if it is available. But now again, let me tell you very frankly that even though that there is a long list here of essential tests for in the PL-HIV under HIV care, but it doesn't say that unless this is available, you cannot start ART. For example, if someone does not have, suppose, urine report, will you withhold ART of that client? It is criminal, because without ART the person is going to die. Without ART the person is going to spread the HIV infection. But with urine report also, at that moment it may not matter that much. So you can start ART even if you don't have this report or blood sugar report. But it doesn't mean that you need not get it done. Don't take it to the other extreme. So it is like that you hasten or you fasten the baseline investigations and then quickly put the patient on ART. But if baseline investigations are becoming a barrier for ART initiation, then I think with 1 or 2 basic investigations, you should be starting patients on ART if they are clinically stable. Now, every word here is important. You need to identify those who are clinically stable. You need to, I'm not saying that this is written in the guideline. Don't quote me for that. But what I'm trying to say is that your baseline investigation should not become a barrier for ART initiation, and that should not become a cause of death for a certain client who is actually eligible for ART soon. VDRL, for example, if it is not available, will you not start that client on ART? You cannot be that rigid in this context. but also that I'm not saying that these are not important. These have to be done. Once you start ART, if something is not available from the list, you can get it done even after initiation of ART also. Again, it depends on what ART you are starting, based on which we are doing the follow-up investigations. Okay, there is a in cryptococcal meningitis, whether to start ART and amphotericin B at the time, or we have to start ART later. For specifically for cryptococcal meningitis, the guideline is that you should delay the initiation of ART. There are some conditions where we delay ART. What I was talking about was absolutely asymptomatic, clinically stable clients. But those with cryptococcal meningitis, those with TB meningitis, the guidelines are delay ART initiation for maybe 4 to 6 weeks. So when you initiate amphotericin B, you can give for 2 to 3 weeks, and then after that, maybe after a month's time, you need to start ART, because the risk of severe iris, which may cause death of the client, is more there. But at the same time, and there is another question on iris. What is your opinion on iris starting ART early or same day? See, iris is something which you cannot predict. There are some basic things by which you can predict iris also, but delay in ART initiation, risk of death is higher. I understand that early ART initiation may result in iris, but most of the times you will be able to manage iris. But if the person dies without ART, that you will not be able to manage, right? So once death happens, it happens. So that is one balance we need to see. And also, believe me, there is no one guideline for all patients. All patients are different. They have different infections. They have different conditions. So you need to take that decision based on that scenario, based on the patient. But program gives a broader guidelines on, like I said, two conditions, cryptomeningitis and TB meningitis. You need to delay ART initiation. At the same time, patient has pulmonary TB, but the CD4 is less than 50. The same guidelines say that you have to start ART if the CD4 before 2 weeks also. So I'm not saying that you have to start ART on the same day. Please don't take it like that. But for each patient, go through all these things and then take your decision. But the ultimate objective should be start ART in all clients as soon as it is possible. But don't hasten. Don't like. If you have any doubt, you take your time. That if the patient is not willing to take, then person will have to be given time. Then once the patient is prepared, then only you will start ART. So it depends on patient to patient. Can TB and ART should be started simultaneously? Simultaneously means it is not the same day. You have to start TB treatment first. See that the patient is stabilized on TB treatment, then you start ART, because if there are any side effects, you won't understand that those side effects are because of TB treatment or ART. All these questions will be answered in this course. So please hold your questions for OIs and all that, because there are separate sessions on them. We'll discuss them in great detail there. Till which time period we can perform remaining routine investigations after initiating ART? Again, it is not a guideline. Please understand the whole thing what I'm trying to say. It is not a guideline that you start ART and then do baseline investigation. It is not. What I'm trying to say is, if the investigations is becoming a barrier for ART initiation, then start ART first. And then you do investigations as soon as possible. But don't let your patients die without ART. So that is the thing. I hope you understood. I have multiple times stressed upon the importance of baseline investigations, but also on the other hand, we need to see based on the facilities available to you at your place. Even though that was the list of essential baseline investigations, we need to see the availability at our place. Okay, what is your opinion of cryptoserum test before ART initiation? Again, it is not available in the program. If it is available, especially for the patients with CD4 less than 200, if it should be done. And there is a WHO guideline also on that you can give prophylaxis of fluconazole 200 mg as a primary prophylaxis for those patients. But those things which are not available in the program, it is okay to not discuss about them in great details here as of now. These are other essential tests, especially in the specific regions. I'll skip through some of the slides because again I had a huge number of slide sets, but we don't have much time now because we said that we'll be finishing on at 12:30, but I think we'll extend 10 minutes more. Those who want to leave can definitely leave after 12:30, so it is optional for the others to be here. So test for special investigations in the Northeast. If you are there, then you have to do HCV and hepatitis B investigations because those diseases are prevalent there. So you should be doing. And like in previous slide, if you are practicing in Jharkhand or Bihar, Jharkhand, and West Bengal and all that, then you should do RK39 strip test to rule out the EOIs. Because some of the diseases are again regional, like leishmaniasis is common in those regions, and then Penicillium marnifi is common in Manipur and areas around that. So those investigations are important. But again, even though these are like I'm spending like 4 slides on investigations, but investigations is something which are good and which are to be done. But all our 540 ART centers are different. They are in different settings. At some clinic, if it is not available, try your best to get it available or to make it available. But if you are not able to do that, then with minimum investigations, go and start ART, but monitor the clients closely. That's what I can say. Now, preparedness is another step where we talk about patients' willingness and assess the adherence to therapy and also understanding of the patient that it is not a curative treatment, but it is one thing which will control the virus of that patient. So this is the most important step, I would say, in the ART initiation, preparedness of the client. And as I said, if you invest more time in the first 6 months, it is great. Now, these are again certain, this is a list of opportunistic infection and when to start ART in those situations. Like I said, TB, if CD4 is less than 50, you can start ART simultaneously also, which means first start TB treatment. As soon as TB treatment is tolerated, you start ART. But if it is TB meningitis, you can delay the treatment for even more than 1 month as well. So PCP, at 3 weeks you can start. Depends on what OI you are dealing with. Based on that, you start ART. So this is a long list. Again, we can see that later when we discuss. Few things about 90-90-90 targets. 90% of the people should know their status. 90% of those who know their status should be on ART, and those who are on ART, 90% should have suppressed viral load. Now, again, a word of preparation, I would say, right now, because now the viral load testing is being done for all our priority clients, and priority has been again widened. So most of the clients will have their viral loads now available. So those who are on ART, if their viral load should be suppressed. So plot your graph at your own ART center and see what is happening in your own district and clinics, because this is what UNAIDS is saying now, that this is what they have achieved. 70% in the first 90, 53% in the second 90, and 44% in the third 90. So this is really bad scenario out here. So we should know about your own 90-90-90 cascade. If not, at least know about your 2.11 cascade. So this is what it should be, that if India has 2.1 million estimated HIV positive population, 1.9 million should be on ART, but now we have 1.2 million on ART. Sorry, 1.9 million diagnosed, 1.7 million on ART. Now we have 1.2 million on ART, 1.5 million virologically suppressed. Right now we don't have complete virological suppression picture, but because viral load is still being scaled up. But as far as estimations and diagnosis is concerned, 1.6 million people know their HIV status, 1.2 million are on ART, but still there is a deficit. So for the first 90, interventions have been again strengthened, where self-testing or is being discussed. Index testing or community-based testing is being promoted. And for on-ART clients now, because our caseload is huge after 2017 treat-all strategy, so that is why differentiated service delivery models are being discussed these days, where most of our stable clients can get 3 months ART at one time, that is multi-month scripting or multi-month dispensation of the client. Because those who are on ART, they face huge barriers to reach to the ART center, and if they are stable, they don't need to come to the ART center every month. So now which patient will be called as stable? So there are criteria by which we define stability. So these are called as stable patients who are on ART for at least more than 1 year, those who do not have any major opportunistic infection, no side effects, no comorbid conditions, good adherence to treatment, that is more than 95% adherence in last 3 months, good understanding of lifelong therapy, and CD4 is not declining, and also viral load is suppressed. So if you have such patients, please give them ART for more than 3 months. Earlier in the national program, it was recommended only for TLE clients. Now it is being recommended for TLE and ZLN also if you have received the letter. But if you have stock of more than 3 months in your center for that particular regimen, you should not hesitate giving 3 months dispensation. Refer to your all office memorandums from NACO to again implement 3MD in your ART clinics. Now for the third 90, those who are on ART, their viral load should be suppressed. Now you have viral load test available with you, and at least see or try to plot the cascade in those patients where viral load is being done. For example, if you are doing viral load for all patients who have completed more than 5 years in ART, try to plot a graph for them and see what has happened with them. Are you achieving 90% or not in your district or state? Viral load, even though now we call it as a routine viral load, earlier we were doing only for immunological failure, now we are doing for other clients as well. So the 4 priorities which NACO earlier recommended, one was immunological failure, then key population groups, and then pregnant women, and also those who are on second and third line ART. But now it has been again broadened enough to include those pediatric patients and those who have completed more than 5 years in ART are eligible for viral load. NACO is in process of installing these machines at many of the high burden centers in the country, but simultaneously we have another mechanism where we are getting these viral load tests done through Metropolis, which is a private lab and who are collecting viral load samples from your centers. So prioritize your patients at your centers. Don't let the slots of Metropolis go empty. Minimum there are 20 slots or 20 samples can be collected by the lab, but you have seen that some of the ART centers are not even giving 20 patients to Metropolis. Don't let that happen. So prepare well for that. Take out your list in the previous week, contact those clients and call them on that day, give ART to them also on that day, and get the viral load done and CD4 done on that day itself. We saw this slide in the continuum of care. Differentiated service delivery, it is nothing but it is a client-centered approach. So whatever is convenient for the clients, we will try to make it happen for that particular client. For testing, for treatment, for viral load, for all other services. So especially for key population clients, we try to get it done in a way in which they actually find it useful. So this is one example. NACO has also rolled out other models at 10 different facilities in the country. These were models which were rolled out by state-rate central societies at Maharashtra, Mumbai, Nagaland, Mizoram, and Manipur, with the help of ITECH and CDC, and also after approval from NACO. So earlier we started with multi-month dispensation. Now it is being given across the country, and in the Northeast we have co-located ART and OST centers. That means oral substitution therapy for IDU population. So where the OST is being given, ART is also being given from those sites. ART dispensation through TI, it is happening in Maharashtra and some of the TI NGOs in Mumbai. and then ART dispensation through prison. So 2 sites in Maharashtra, 1 site is in Northeast is in Aizawl. ART dispensation through police hospital in Mumbai, ART dispensation through urban health clinic in Mumbai. At some of the ART plus centers, ART initiation is being done. Now all these are directly supervised differentiated service delivery models. You cannot just do it everywhere and anywhere, but there is a concept which is written and it is sent to SACS and NACO for approval, and once NACO approves, these models are being implemented. Again, the crux of all this is those who require ART should get ART as soon as possible. Those who are on ART, they should remain on ART without becoming LFU or death. And those who are on ART, their viral loads should be below detectable levels or at least less than 1000 copies per ml, so that they are not able to spread the HIV infection. If we do all this combined, then you will be able to bring down the new infections below deaths, and in that sense you will achieve the epidemic control. I think that is what I just incorporated in this particular session. I don't know if this was helpful, but overall I tried to actually mix things which were already presented by UW faculty and also what is the national perspective. So this is the way I look at it. All these clinical contact session, we can use the time in this way. As I said, if you are interested, please let us know your names and area of interest or topic of interest. And if there is no if you want to take or facilitate these sessions, you can surely facilitate. And if you need help in that also, we can be around for those sessions as well. We can do it together. So thank you very much for your participation, and the test result, as just a reminder about the quizzes. So the quiz is due. Shweta had reminded me. Just I'll check and let you know. I think you all are aware. When is the quiz due? Uh, 14th April. Yeah. So April 14th is the deadline for the quiz. So please don't miss that deadline. It will be, I think, 7 marks quiz, and you should be attending that or solving that as soon as